Welcome to Skin Sync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Hi, everybody. We're here with special conference coverage at Rapids 2026 in beautiful Fort Lauderdale. I'm Eileen Cheever, and I'm here with the wonderful Dr. Asempa. Hey, Dr. Asempa.
Hi, how are you?
I'm
Thanks for having me.
well. Thanks so much for coming. So, hey, let's dive right into that first lecture that you gave about scarring and non-scarring alopecia. You gave such a practical but systematic way to approach it. Give us some pearls and tips from that presentation, that first part.
Yeah, no, I think the important thing is to really know that you're doing the same thing for each patient so you don't miss anything. So I start off with history, asking the patient how long it's been going on. I have a whole list of questions that we ask about for each patient. And then second to that is your global exam. So that means to me what you see when you look from the door, what you see when you part through the hair with your hands. And one of my big tips is you always need to get in there. You always got to separate to the scalp. You really can't diagnose hair loss just from looking how they're sitting. You really got to kind of get to the root, no pun intended there. And then number 3 is the most important for me. It's trichoscopy. That's the physical exam with the trichoscope or with the dermatoscope. And that's what gives you kind of a microscopic image of what's going on. And then, of course, histology, getting a biopsy. In some cases, trichoscopy is not enough. And then we need to get that, really truly look under the microscope. Blood work. So I'll look at their old blood work and then maybe order some new blood work. And then, of course, response to treatment, right? So if I think it's something and they respond, maybe I'm right. But if I think it's something and they don't respond, instead of thinking it just doesn't work, maybe I have the wrong diagnosis.
And it was really from the podium. Put your hands on the patient, touch the patient, get in there and look. It
Yeah.
really does resonate with the patient. And it really says that you're, in it to kind of win it, but also really being able to be thorough.
Right. Okay.
So you mentioned trichoscopy in your lecture. It's such an underappreciated art. What can you tell us about those features you're really looking for? What are you honing in on? What are you looking for when you use that device?
Absolutely. So, I tell everyone, especially my residents and trainees, there are 5 things you want to look out for every single time that you look through your dermatoscope. So number 1 is what the actual hairs themselves look like. What is their caliber? Are they thin? Are they large? What do they look like? How many of them are coming out of each follicular orifice? Then number 2, you want to look at the pigment. Is there any pigment on the scalp? Are they hyperpigmented? Are they hypopigmented? How does the pigment look? Then what about the vasculature? How is the vasculature, right? Do they have redness? Are there enlarged vessels? Then you want to think about just the interfollicular space overall. How much space is there between the hairs? Are they close to each other? Are they far away from each other? Are you missing follicles in between those hairs? And then lastly, scale, the presence of the scale and the position of the scale. So is there scale? And then where is it? Is the scale in between the hairs or is it around the bottom of the hairs? And those are the 5 things that really tell me what the diagnosis is from the trichoscopy.
Really be able to bring that into full view.
Exactly.
Yeah. And it's complementary to a biopsy and your blood
Absolutely.
work and
Yeah.
listening to that patient history. It's just really an essential part of diagnosing.
Absolutely.
You had mentioned some styling pearls. You mentioned some hair loss and styling guides for
Yeah.
patients. What can you tell us about that?
Yeah, so we have 15-minute visits, so it's so tough to be able to talk to them about styles, but their styles are going to make a huge difference in their treatment response. If it's a patient who's doing really tight styles, or if it's a patient who's doing, a style where we can't actually access the scalp every day, then of course my treatment's not going to work if I want you to do something on the scalp topically every day. So I have a guide that I give to my patients to help save me time, but also to give them an in-depth understanding that goes through grading hairstyle, style A, grade A, B, C, or F based on its ability to promote hair health and prevent hair loss or promoting hair loss, unfortunately. And that really helps to save time because I say, hey, I think that the style that you're currently doing may not be the most helpful or it may be contributing. Let me let you have this guide, take a look through it, tell me what your thoughts are. And then when we come back, we can talk more about, styling practices that may be more supportive of our treatment regimen. And that really tends to work well.
And I love the tone of that conversation because the last thing you want to do is go through that examination, take that history and say, you're styling
Yes.
your hair wrong. That's
Yes.
just such a beautiful way to
Yeah.
just open up that conversation, instill that
Absolutely.
trust, but also provide them with the education that they may really need regarding styling.
Absolutely. Absolutely. And I never tell a patient not to do a style directly just because styling is so emotional, it's spiritual, it's religious. I mean, there's so many factors that come into why someone's doing what they're doing. So I like to let them know how it may be impacting their scalp and then how we can mitigate that. And there are some patients who tell me, I hear what you're saying and I'm still going to do this. And I'm like, okay, let's try our best without, with what we're doing. But I want them to understand the impact that it may have.
The diagnosis of LPP shifting a little bit can be a little bit elusive. It can be tough. Sometimes it just starts with these patients mentioning tenderness and sensitivity, but then we also see that with CCCA. How can trichoscopy help? What are some differences you'll see on biopsy? Any pearls for treatment?
Yeah. So, with LPP, and there's no perfect exact science. Like they do tend to look a little bit different on trichoscopy. CCCA doesn't have as much prominent scale for all of my patients as LPP does. But you're right. There are some patients who the trichoscopy can look very similar. And that's when sometimes biopsy can help to differentiate between the two. And I think it's worth it because there is a slightly different treatment algorithm for both of them. But classically, with CCCA, you're only going to see it in African American patients. So that can help from a demographic standpoint. With LPP, you can see it in both, any kind of patient. But then you want to think about really vertex scalp, a lot of tenderness, whereas CCCA, half of my patients have no tenderness at all. Some have a lot, but most of my LPP patients are really tender, really red. And then again, that perifollicular scale that's so prominent compared to CCCA, where you have that perifollicular hyperpigmentation or that gray color. Really, with LPP, you get really a lot of scale right around that follicle.
Interesting finding on exam. And, lastly, before we transition to talking about some of your cases, what's kind of the current thinking about really the pathophysiology behind what we know about alopecia areata? What role does cytokines play and that loss of follicular immune privilege? Can you expand on that a little bit?
Yeah, so I tell my patients often, like, your hair, the bottom of your hair is supposed to be hidden from your immune system, right? It's not supposed to be seen by it because hair, when it is in the skin, right? And we see this also, and I guess we'll talk later in acne keloidalus nuchae and other things. When hair gets into the skin where it shouldn't be, when it's not covered by that, immune privileged follicular site, the body treats it as foreign, and then your immune system then attacks it. So when you lose that immune privilege, the body is able to see the bottom parts, the antigens that are shown by the follicular area, and then you get that, those T lymphocytes attacking the bulbar area, the lower portion of the hair. Now, the good news in alopecia areata is that the bulge region where the stem cells are is not by the bulb. So BULGE versus BULB, right? And so you get like a swarm of bees, those lymphocytes around that bulb, but they're not in the area where the stem cells are. So the inflammation is robust, but it's not causing permanent damage to the follicle like it would in, for example, lichen planopilaris, where that, lichenoid inflammation is in that isthmus region by the bulge. So it does kind of cause that damage to the stem cells and cause permanent hair loss.
So if you really know the anatomy of what that hair follicle looks like, it's really
Yes,
easy to isolate where that immune disease exists and really where it doesn't.
exactly.
Hey, and you mentioned it's a great segue into AKN and the case portion of your presentations today.
Yeah.
You spoke about that gentleman who had AKN, a mid-30s-year-old gentleman with AKN. Such a tough condition.
Yeah.
Talk with us a little bit about that.
Yeah, it's a very tough condition. We think of it as multifactorial. The name acne keloidalus nuchae is a misnomer because there's no true acne, there's no true keloid, and it's not always in the nuchal area. So, funny name, but it is commonly in the nuchal area. But you definitely will see it presenting higher up. So, I tell people first thing when you're treating it, look at the rest of the scalp, right? As with every single hair loss patient, look at the rest of the scalp because they often have papules and bumps kind of higher up, even on the crown or even sometimes the frontal scalp for a disease that's supposed to be in the nuchal region. I start off with topical antibiotics and topical anti-inflammatories, and then sometimes we do injected anti-inflammatories like injected steroids, and then sometimes even systemics. Sometimes we need systemic retinoids, sometimes we need systemic antibiotics to really calm it down. And worst case scenario is surgery. People will get the whole area cut out.
And are you giving any types of tips or tricks or pearls in the counseling portion of your visit
Yeah.
for, say, gentlemen with AKN best practices that
Yeah. No, absolutely. When we call it multifactorial, it's because the hair removal practices are only part of the story. So even if they remove their hair in a perfect way, they still can have the disease. So I have to explain that to them first. But definitely we want them to avoid direct shaving of the skin with a razor because it's really definitely inflammatory. And we want them to avoid things that are constantly rubbing on the area like helmets or hats. Sometimes they can't avoid it. If they're a football player, you're going to have the hat rubbing, right?
military service or
Military, so
civil
many things.
service? Yeah.
Exactly. And I do a lot of waivers for military as well, to try to get them to not have to shave necessarily. But it can be really tough.
Interesting. What about Demodex? A pathogenesis in terms of correlation with Demodex? What
Yeah.
can we know about
So,
that?
so what we learn is that male pattern hormones, so androgens probably play a role, right? Friction in the area probably plays a role. And then immune response or an abnormal immune response to what we call commensal flora. So Staph aureus and Demodex mites. They live on the skin. They're supposed to be there. But sometimes the immune system is a little bit more aggressive in recognizing them. So sometimes when we use things that can kind of help to reduce that there, even sometimes like selenium sulfide or sometimes like the topical topical antibiotics that can be helpful to reduce the burden of commensal flora.
And mostly males, do we think androgens play a role distinctly with our male patients?
Definitely, just because we see this significantly more in male patients, right? Even when we control for how often people have things that are rubbing on the area, how often people are shaving it down. Now, of course, friction is more common in male patients because they're more likely to have the short haircut. But we definitely do think that androgens are probably playing a role.
Well, the cases really help bring that science to life. And
Yeah.
like just a great learning opportunity.
Thank you.
Dr. Asempa, thank you so much for joining us
Thank you for
here.
having me.
And we'll talk with you soon.
Okay, thanks.
Thanks for tuning in to SkinSync. Don't forget to subscribe to SkinSync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.